Imagine this scenario, something medical teams face, well, every single day.
Mm-hmm.
You've got a critically ill patient, maybe someone you know in the ICU.
Right, they're incredibly fragile.
Exactly. Every breath is a fight, every heartbeat watched like a hawk. They're hooked up to everything, vital signs all over the place.
And their condition is just so unstable, even moving them feels risky.
A huge gamble. And then, bam, the doctors deliver urgent news. We need to do surgery now. Life-saving procedure.
Uh-huh. Absolutely necessary.
But that traditional operating room, the OR, it feels miles away.
And the journey itself, it could be fatal for someone that unstable.
It's a really high-stakes dilemma, isn't it? Choosing between the ideal surgical setting and the patient's immediate urgent needs right there.
It absolutely is. And historically, that trip to the OR was often, well, the only option, no matter how precarious the patient was.
Right, and that choice often carried immense risk. But what if? What if that vital procedure could happen right there?
Not in the OR.
No, in the ICU. At the patient's bedside.
Mm.
That's the remarkable shift we're diving into today.
It's a groundbreaking change in critical care.
It really is. So this deep dive is all about how modern medicine is basically revolutionizing critical care, bringing these complex surgical procedures right to the patient. Our mission today, to unpack why this is happening, how it's safely managed outside the OR, and the specific, often life-saving procedures involved.
We want you to really get a robust, professional-level grasp of this evolution.
Exactly. Mastering it like the elite pros in the field.
And to do that, we're drawing insights straight from the source, a definitive surgery textbook packed with expertise from leading figures.
So this isn't just about convenience.
Not at all. It's a fundamental reimagining of where healthcare happens, profoundly changing how we care for the most vulnerable.
Okay, so let's unpack this. To really appreciate the innovation, we first need to understand the gold standard, the traditional OR. Why is it usually the ideal place?
Well, it's the standard for very good reasons. The OR is basically a highly centralized, meticulously designed hub. Think resources.
Right. Specialized people, specialized gear.
Exactly. You've got specialized anesthesia folks, anesthesiologists, nurse anesthetists, masters of the whole spectrum of anesthetics, constantly monitoring vitals.
They're managing pain, stability, ready for anything.
Precisely. Then there's the equipment, a comprehensive array of surgical tools, instruments, all sterile, all organized.
Ready for whatever the surgeon needs.
And dedicated radiology support. Imaging like fluoroscopy or ultrasound right there mid-procedure, critical for guidance sometimes.
And the nursing staff, also highly specialized.
Absolutely. Highly trained nurses and procedural staff, scrub nurses who know the instruments inside out, anticipate the surgeon's needs, maintain that sterile field.
Laser focus.
And circulating nurses managing the room, supplies, documentation, communication. It's a whole ecosystem.
And the environment itself designed for safety.
Exactly. Strict safety policies, principles. It's an incredibly controlled, sterile space.
Right.
Meticulous temperature and humidity control, advanced air filtration to cut infection risk way down, immediate lab access for blood work,
Wow.
and, of course, the dedicated scrub area. The whole setup is optimized for complex, precise work, controlling every possible variable.
Okay, so a finely tuned machine, maximum safety, maximum efficiency, which really begs the question, why ever leave it? Why move procedures out of this seemingly perfect place? This gets really interesting, the challenges and risks of moving critically ill patients to the OR.
This is the core issue. It often boils down to logistics and, crucially, patient stability. Or space is finite.
Right, high demand.
Incredibly high demand. It often exceeds what's available. So even for urgent or emergent cases with critically ill patients, getting timely OR access can be a huge problem.
You mean delays?
Significant delays. Or sometimes it prevents the procedure entirely when time is absolutely critical for a deteriorating patient.
A scheduling nightmare on top of a medical crisis. And then there's the transport itself.
Yes. The inherent risks of transport. As patients get sicker, more complex, more unstable, the risk of moving them, even just down the hall, skyrockets.
It's not just the movement.
No, it's everything. These patients are on multiple life supports, disconnecting them, even briefly, immediate risks. Their status can destabilize fast position changes, temperature changes, gaps in monitoring.
I see, like someone on high ventilator support.
Exactly. Even a short time on a transport ventilator might be less sophisticated than their ICU machine. That could lead to lung injury.
Wow. And the people needed for transport.
It's a massive undertaking. often needs a large multidisciplinary team.
Ooh,
Nurses, dedicated transport staff, respiratory therapists, anesthesia staff,
okay.
all focused on moving one patient safely.
That's a huge resource sink, as the text calls it.
It really is,
Yeah.
pulling vital staff away from other critical patients in the ICU who also need them.
And every handoff, every change of personnel or location, that introduces risk, doesn't it? Communication gaps.
Inherently, yes. Detailed, precise communication is vital for handoffs, but every transition point is a potential source of medical error.
Like dropping the baton in a relay race.
A good analogy, a missed detail, a misunderstanding, it can have critical consequences.
And cost. I imagine this isn't cheap.
Definitely not. Transporting a critically ill patient is resource-intensive people, equipment, and adds considerable cost to their hospital stay. Or fees, transport charges, indirect costs. It all adds up.
So the decision to transport needs careful thought, like any other treatment.
Exactly. You have to weigh the risk versus the benefit for that specific patient, which is why hospitals need robust, clear guidelines for intra-hospital transport to mitigate these risks.
Okay, so we have this tension. The OR is ideal, but getting there is risky, complex, costly. The solution, bring the surgery to the bedside. Let's talk benefits.
The benefits are really compelling, truly transformative. First, bedside procedures directly address and limit those significant transport risks.
You just bypass the journey.
Exactly. Eliminate the physiological stress, the equipment disconnects, the handoff points. That immediately boosts patient safety.
Makes sense. And timing. Flexibility.
Crucial element. Bedside procedures offer vital flexibility in timing and scheduling. Instead of waiting for an OR slot, which can mean dangerous delays,
Right.
these can often happen when the patient is most stable or when the right ICU team and resources align best. Less delay for crucial interventions.
Which could literally save a life.
Absolutely. And then there's cost reduction. You avoid OR fees, transport costs, the big personnel mobilization, significant savings.
Which is always a factor in healthcare.
And maybe most importantly, as you said, these procedures can be genuinely life-saving for patients too unstable to even survive transport.
The ones who just can't make the trip.
For them, a bedside procedure is that crucial, immediate intervention. Time and stability are everything. It fundamentally shifts how and where critical care happens.
A powerful transformation.
That's it.
But how does it actually work? How do you replicate that controlled, resource-rich OR environment in an ICU room?
It's a testament to medical ingenuity, really. The ICU isn't an OR, obviously, but it has surprisingly similar core capabilities.
Like monitoring?
Exactly. Both places have advanced real-time monitoring, cardiovascular, respiratory, neurologic. The ICU is designed for continuous, intensive physiological oversight. Heart rate, blood pressure, oxygen, brain activity. It's all there.
And ventilation. That's key in the ICU.
A significant point. Both have mechanical ventilation. But interestingly, many ICUs actually have ventilators with more advanced functions than typical OR ventilators.
What is that?
ICUs manage highly complex respiratory patients long-term, often pushing the limits. So their ventilators need more sophisticated modes. This is a big plus for doing procedures right there.
Okay. What about anesthesia? ICUs don't typically have those gas machines, right?
That's a key difference in how it's delivered. ICUs generally lack inhalational anesthesia setups, but they are fully equipped and staffed to give sophisticated intravenous sedation and analgesia.
IV meds instead of gas.
Right. And that approach is more than enough for a wide range of bedside procedures. It ensures comfort, pain control, safety. So the core life support monitoring comfort systems, they're already robustly in place.
So the tech infrastructure is largely there. But the people, the OR has very specific roles. Scrub nurse, anesthesia team. How do you translate that to an ICU staffing model?
That's where teamwork and adaptability are absolutely key. The critical care nurse, who knows that patient intimately, moment by moment, they can effectively take on many functions of the circulating OR nurse. Managing supplies, procedural flow, positioning, documentation.
Okay. And anesthesia needs.
The combined expertise of a respiratory therapist managing the ventilator and the intensivist, the critical care physician overseeing the patient's whole status, can manage sedation and anesthesia needs seamlessly.
Sort of analogous to the OR anesthesia provider team.
Very much so. Continuous vigilance over airway circulation. It's covered.
But there's still that one role, the scrub nurse or tech. Handling sterile instruments, anticipating the surgeon. That seems hard to replicate easily.
You've hit the crucial gap. That role needs highly specialized training in instrument handling, anticipating moves, maintaining absolute sterility.
So how do you bridge that gap at the bedside?
The key innovation has been employing dedicated procedure support personnel, specifically within the ICU.
Specialized ICU staff for procedures.
Exactly. Rigorously trained to take on many of the scrub nurse's functions. They ensure instrument management, sterility, efficiency are maintained to the highest standards, even outside the OR. They're the guardians of the sterile field in this setting.
It sounds like building this system, moving high-stakes procedures, requires meticulous planning. What are the absolute must-haves for a successful bedside procedure system? Thinking about figure 23.2 from our source.
That figure really lays out the fundamentals. First and foremost, robust management guidelines. This means detailed standard operating procedures, SOPs, for every step.
Like a playbook.
Precisely. Comprehensive pre-procedure checklists, including those crucial timeout protocols we need to discuss more, and well-defined sedation protocols. These aren't suggestions, they're mandatory. They standardize complex processes, reduce variability, boost predictability.
Making sure everyone's on the same page every time. Consistency.
Absolutely. Next critical element, a streamlined supply chain. If you're bringing the OR to the bedside, you need efficient, immediate access to all supplies, no exception.
How does that work practically?
Usually involves temporary but well-organized storage of core equipment and instrument trays right in the ICUs, plus standardized, efficient restocking to ensure everything, scalpels, sutures, catheters, is always available right when needed. No delays.
Having the right tools at your fingertips, literally.
Exactly. And the final piece beyond protocols and gear is maybe less tangible, but just as vital.
What's that?
The facilitative mindset. A positive, collaborative, adaptable attitude among all staff is vital for success.
Culture matters.
Hugely. Everyone, nurses, intensivists, RTs, procedure support needs to be aligned, adaptable, committed to making it work safely and smoothly in this non-traditional space. It emphasizes the human element of safety. Cooperation, proactive problem solving, just as crucial as technical skill.
This sounds incredibly intricate. Safety must be the absolute bedrock. How do you ensure doing complex surgery in an already complex ICU is genuinely safe with outcomes like the OR?
That's the critical foundation. Performing bedside procedures safely, low infection rates, patient comfort, amnesia absolutely mandates appropriate case selection and rigorous, consistent safety practices.
Because the ICU is already a high-risk environment.
Exactly. It's complex, full of sick patients, multiple interventions, frequent changes. You have to recognize the numerous potentials for error and adverse events. You can't just react. You have to be intensely proactive.
So this is where ideas from other high-reliability fields come in, like aviation, nuclear power, where tiny errors are catastrophic.
Precisely. Like those industries, preventing medical error requires extreme standardization and eliminating variability wherever possible. The goal is to make the safest action the easiest and most consistent action, designing systems resilient to human error.
A powerful concept. I know the source material mentions adopting the WHO's Safe Surgery Saves Lives program. What is that, and what impact has it had?
It's a huge global initiative, a real game changer. Implementing it has been linked to a significant global reduction in perioperative morbidity and mortality. It provides a systematic framework so critical steps aren't missed.
It has specific objectives, right?
10 of them. Yes, 10 core safety objectives from the 2009 WHO guidelines. Each targets a specific risk area.
Okay, let's walk through them. What's number one?
Absolutely fundamental. Correct patient, correct site. Ensuring the team operates on the right person at the right location. Sounds basic, but mistakes happen. Multiple checks are needed.
Number two.
Anesthetic safety. Using methods known to prevent harm from anesthesia while managing pain effectively. Meticulous assessment, drug selection, monitoring.
Third.
Airway and respiratory function. Recognizing and preparing for life-threatening loss of airway or breathing, especially critical in the ICU. Emergency gear ready, clear plan B.
Fourth.
Blood loss management. Recognizing and preparing for high blood loss risk. Anticipating needs, having blood ready, clotting status known, hemorrhage control strategies planned.
Okay. What about allergies or adverse drug reactions?
That's 5. Avoiding known allergic or adverse drug reactions. Thorough checks of allergies and medication history before giving anything new. Simple check. Saves lives.
And surgical site infections, always a concern.
Objective 6. Minimizing surgical site infection risk. Meticulous skin prep, strict sterile technique, careful wound care, appropriate pre-op antibiotics.
Then the worry about things left inside.
Objective 7. Preventing retained instruments and sponges. Meticulous counting before, during, after. Everything accounted for.
Handling specimens.
Objective 8. Securing and accurately identifying all surgical specimens. Crucial for diagnosis, pathology, treatment planning, no mix-ups.
Communication keeps coming up as vital.
And it's objective 9. Effective communication and information exchange. Clear, concise handoffs, discussing potential issues, ensuring everyone's informed, speaking up, active listening.
And the last one looks at the bigger picture.
Objective 10. Routine surveillance by hospitals and health systems. Tracking surgical capacity, volume, outcomes. Allows continuous quality improvement, spotting trends, assessing resources. These 10 together create a robust safety net.
A comprehensive framework. You mentioned those dedicated procedure support personnel earlier. How do they specifically boost safety in the ICU?
They greatly facilitate reducing variability. They're the consistent element. They ensure strict compliance with SOPs, manage the setup and sterile field meticulously, and minimize communication errors by being a central point for instrument and supply needs.
Like a procedural specialist right there.
Exactly. And limiting this role to a small number of highly trained people fosters greater expertise, which is extremely valuable for safety, especially managing the airway during delicate things like tracheostomies, where a tiny mishap can be catastrophic.
So they're not just following protocols, they're experts in them.
And they're charged with developing, monitoring, and applying safety practices across all procedures. They're the guardians of procedural consistency and improvement.
Okay, so it's having the protocols and having dedicated people ensuring they're followed. What about implementing those guidelines themselves?
They must be present, mandatory, enforced before routine bedside procedures begin. They need to be consistent with OR procedures to reduce variability, easily accessible to everyone, and compliance must be continuously monitored.
Can they be adapted for different ICUs?
Yes, customization for specific ICU variations is fine as long as core safety isn't compromised, but the guidelines must address key things. A clear case selection criteria, mandatory personnel needed, required equipment and meds, precise continuous monitoring parameters, BP, ECG, pulse ox, ventilation.
It's very detailed.
Absolutely. And adequate staff must be present for the procedure itself, for monitoring sedation, giving meds, managing the ventilator, and meticulous documentation. Analgesia and sedation must be directed by credentialed personnel, with clear standards for prep, equipment, and counts. It's a multi-layered safety framework.
I can see the need for that level of detail. Now, timeouts in surgery, I hear that term a lot. How do pre-procedure timeouts and checklists, like in Fig 23.3, fit into bedside safety?
They are absolutely vital. Vital for safety, limiting communication errors, ensuring compliance with those SOPs. It's that final critical pause before starting.
What happens in a timeout?
The whole team surgeon, intensivist, nurse, RT, procedure support stops. They verbally confirm crucial details. Patient identity, the exact procedure, correct site marked invisible, all equipment ready, explicit verbal sign-offs from everyone.
Everyone confirms out loud.
Yes, it also helps with documentation and compliance monitoring. And keeping it consistent with OR practice reduces variability. It's that crucial moment to catch potential errors before they happen. A final safety net.
And once these are routine, how do you keep improving? It can't be static.
Absolutely right. Continuous improvement through tracking and reporting is essential. You need robust ways to track procedure performance, monitor compliance, review, and report any adverse events.
Learning from experience.
Constantly. These mechanisms need to work locally in the ICU for consistency, but also integrate with hospital-wide safety initiatives. We often use process maps, flowcharts, visual tools to integrate unit, department, and hospital processes, clarifying communication and authority lines. It's a closed-loop system. Safety, learning, refinement.
A truly rigorous system. So with all this in place, how do clinicians actually choose which patients get bedside procedures? It sounds like a complex risk-benefit calculation every time.
It is indeed a delicate balancing act. When patients are appropriately selected using these criteria, bedside procedures can achieve similar complication risks to the OR.
But without the transport risk, and often at lower cost.
Exactly. But, and this is crucial, the current evidence base is still evolving. There aren't tons of randomized studies or large reviews for every possible bedside procedure or patient type.
So it's not black and white yet. Requires judgment.
Precisely. Safety and efficacy can vary based on local experience and how well those safety practices are applied. As places get more experience, indications might broaden, frequency might increase, but the decision always needs a meticulous, individual risk-benefit analysis.
What factors go into that analysis? What's being weighed?
Several critical things: the difficulty and risk of transporting that specific patient, the complexity of the operation itself, some are just too big for bedside, the ability to get OR time, promptly that bottleneck issue, and then the safety, ease, and cost savings of doing it right there.
But major, complex surgeries still mostly belong in the OR.
Generally, yes. Factors favoring the OR usually include complex procedures needing extensive, non-portable equipment, high risk of massive bleeding requiring immediate large-scale resources, inserting prosthetic materials where absolute sterility is paramount, significant lighting needs, and very lengthy procedures needing prolonged OR support.
Okay. So if the OR is for the most complex, what are the main reasons, the indications for choosing bedside? Sounds like two main categories.
That's right. Two distinct categories. First, life-saving intervention for the unstable patient.
The patient who absolutely cannot be moved.
Exactly. They need an urgent life-saving procedure, but they're too unstable, profound shock, severe respiratory failure to survive transport. Their survival depends on doing it right there, right now.
And the second category, less immediately critical.
Correct. Low-complexity procedures with clear advantages. These are procedures where the risks of transport, the OR scheduling hassles, and the higher cost and resource use of the OR clearly favor doing it at the bedside.
Where the benefits of avoiding transport just outweigh any marginal OR benefit. More efficient, maybe better patient experience.
Precisely. Cost-effective, too.
Can you give us some examples? What procedures commonly fit these criteria?
Sure. The list includes several now routinely done bedside. Percutaneous and open tracheostomy, we'll get into that. PEG and PEG-J tube placements for feeding. Fiber optic bronchoscopy. Soft tissue wound debridement, critically important. Decompressive laparotomy for abdominal compartment syndrome.
Wow. Opening the abdomen bedside.
Yes. Also, washout and packing removal after damage control laparotomy, placing IVC filters for blood clots, even some damage control orthopedic procedures like placing external fixators on unstable fractures.
A surprisingly wide range. Is there also a role for bedside procedures as a bridge, a temporary fix?
Yes, extremely important point. Sometimes a bedside procedure is done to temporize, to stabilize an extremely critical patient. Maybe a patient with severe sepsis, suspected abdominal source, but too unstable for the OR trip. A quick bedside laparotomy might just drain an abscess or pack bleeding. It buys time.
Allows them to stabilize before a bigger surgery.
Exactly. They get stable, then go to the OR for the definitive operation. It leverages the bedside option to make the next step safer and more successful.
That brings us to specifics. Let's start with bedside laparotomy, opening the abdomen. You said its use has evolved dramatically.
It really has. Initially, it was seen as a procedure of last resort, a heroic attempt on dying patients hoping to find something reversible as they were crashing.
A last-ditch effort.
Pretty much. But recently, its use has seen a dramatic increase in more controlled, strategic settings. It's not just desperation anymore.
What drove that shift? Why use it more strategically now?
Two main things. First, better recognition and understanding of abdominal compartment syndrome, ACS. We now know it's a frequent, severe complication in acutely ill patients, especially after massive resuscitation.
And second,
widespread acceptance and refinement of the damage control approach for severe intra-abdominal problems, both in trauma and general surgery.
and both often lead to an open abdomen.
Yes. The fascia, the abdominal wall muscle covering, is left open. This requires temporary closure techniques, often negative pressure systems. Nowadays, they manage fluid well and help bring the edges back together later.
So these are emergency or very urgent situations.
Right.
What are the specific indications for a bedside laparotomy, box 23.1 in the source?
Right. They fall into emergent or semi-elective. Emergent indications include decompressive celiotomy for ACS, that life-threatening pressure buildup, controlling and packing recurrent bleeding after a previous damage control surgery, they're rebleeding and can't be moved, and suspicion of intra-abdominal infection in patients too unstable for transport, maybe due to extreme ventilator needs or shock.
Yeah, the semi-elective ones. More planned.
Usually part of a staged approach. Semi-elective indications include planned pack removal after damage control, irrigation and debridement of an open abdomen, cleaning it out, achieving source control for sepsis from an abdominal issue, maybe less acutely emergent, and managing traumatic abdominal wall defects.
Let's deep dive into ACS. Historically, the most common emergent reason for bedside laparotomy. What exactly is it, and why is it so dangerous?
ACS is critical. It's a sustained pathological rise in intra-abdominal pressure. IAP. Pressure builds up inside the abdomen.
Squeezing things.
Essentially, yes. It profoundly alters body function. It reduces abdominal perfusion pressure, less blood flow to gut, kidneys. It restricts venous return to the heart pressure, compresses big veins, and it reduces pulmonary compliance. Lungs get stiff, hard to ventilate.
What does that do to organs?
It can rapidly cause cardiac failure from low return, severe pulmonary failure from stiff lungs, and oliguria, low urine output, leading to kidney failure as kidneys get squeezed and underperfused. Severe IAP causes widespread organ hypoperfusion and ischemia, lack of blood flow and oxygen.
And it can be primary or secondary.
Right. Primary ACS is from problems inside the abdomen, bleeding, fluid after injury. Secondary ACS is from bowel edema and fluid buildup due to treating extra abdominal problems like massive resuscitation for burns or sepsis elsewhere. The body's inflammation causes fluid leak into the abdomen.
How do you measure and grade this pressure?
Usually measure IAP via a bladder catheter. Reliable method. Grading systems exist. Grades 3rd, IAP 21 to 25 mmHg, and 4V, IAP 25 mmHg, are significantly elevated and define ACS, needing immediate action.
So lower pressures might just need monitoring or supportive care?
Yes, maybe measures to ensure adequate abdominal perfusion. But as IAP climbs into those higher grades, abdominal decompression via laparotomy, opening the belly, becomes indicated, often life-saving.
And recognizing it early is key.
Absolutely. Routine bladder pressure monitoring is crucial for high-risk patients, like those getting massive fluid resuscitation after abdominal surgery, or shock patients with a high base deficit.
Remind us base deficit.
It's a lab value showing acid buildup from lack of oxygen to tissues. A base deficit over 10 means severe metabolic acidosis, severe shock, a big warning sign.
So shock patient, high base deficit, getting lots of fluids, or blood-high ACS risk. Monitor bladder pressure.
Exactly. And worth noting, ACS incidence might change as resuscitation strategies evolve.
Okay. And damage control laparotomy. Increasingly done bedside for trauma.
Yes. It's an abbreviated surgery, mainly to save trauma patients bleeding to death, exsanguinating. Goal is stop bleeding, prevent contamination, then stabilize physiologically.
Not fix everything at once.
Right. This approach led to more bedside laparotomy to control recurrent bleeding before the patient is stable enough for a full OR trip.
Yeah.
Also used for later pack removal, irrigation, debridement.
Common in big trauma centers.
Very common in levelized centers where damage control and temporary abdominal closure for patients in extremis near death are frequent. Lots of temporary closure methods exist. Negative pressure systems preferred now.
And this open abdomen idea isn't just trauma. General surgery, too.
Yes, definitely. Increasingly used for complex general surgery conditions, necrotizing pancreatitis, necrotizing soft tissue infection of the abdominal wall, diffuse peritonitis, especially high-risk patients, mesenteric ischemia.
What techniques are used?
Staged GI reconstruction, serial washouts for source control, delayed wall closure, manage severe conditions strategically, but important caveat, controlled trials are limited. Optimal indications aren't fully nailed down. Needs ongoing research, careful judgment.
Given how critical these situations are, what's the reality? The outcomes for patients needing this bedside surgical rescue?
It is high stakes. For selected critically ill patients with severe cardiopulmonary instability precluding any transport, a resuscitative bedside laparotomy might be their only shot. The grim reality. Patients needing emergent bedside laparotomy have an extremely high rate of death, with over 50% mortality.
Over half don't survive.
Yes, that critical info is vital for counseling families beforehand. Setting realistic, though difficult, expectations about the severity and prognosis. It's a desperate measure for desperate situations.
Okay, moving to our next common bedside procedure. Tracheostomy. You said this is the most common surgical procedure in critically ill patients needing long-term ventilation.
That's correct. Tracheostomy, whether open or percutaneous dilatatational PDT, has become the standard bedside procedure in many places. Ease and convenience are big factors. Table 23.1 in the source lays out the indications, 3 broad areas.
What are those 3 main reasons for a trach?
First, upper airway obstruction, maybe a difficult airway, major facial trauma, angioedema, that rapid swelling, or airway tumors blocking breathing.
So physically can't breathe through the normal route.
Right. Second, prolonged mechanical ventilation. Patients expected to need the ventilator long-term, especially those on high settings, high FiO2 or PEEP.
Remind us what high FiO2 and PEEP mean again.
Sure, FiO2 is fraction of inspired oxygen. Over 70% means very poor lung function, needing lots of extra oxygen. PEEP is positive end expiratory pressure, keeps air sacs open. Over 10 centimeter H2O means stiff, hard to ventilate lungs. Both signal severe lung issues needing long-term support.
Got it. And the third indication?
Neurologic condition preventing safe extubation. Things like severe brain injury, spinal cord injury, especially with halo fixation, severe agitation delirium, or prolonged coma where they can't protect their airway.
Makes sense. Are there times you wouldn't do a track? Contraindications?
Yes, Table 23.1 lists them, but note, nearly all are relative, often temporary. Things like recent neck surgery, 7 days, high intracranial pressure, severe hemodynamic instability, high bleeding risk, local infection malignancy at the site, or predicted early death where it won't help much.
You mentioned open versus percutaneous, PDT. Is one better for bedside?
Both can be done safely bedside. Guidelines show neither technique is definitively superior for reducing overall complications or death, but PDT has shown advantages in critical care. Decreased wound infection, less clinically relevant bleeding, and multiple studies show PDT is more cost-effective in ICU patients.
That's a significant advantage. And the safety data for PDT.
It's quite strong. Major complication rate seems very low, less than 0.2% in randomized studies. That's less than 2 per 1,000. A large review of over 3,000 PDTs found a major complication rate of just 0.15%, minor rate 1.25%, even held true in obese patients.
That's reassuringly low.
It is. This data helps when deciding, especially if the risk of failed extubation is potentially fatal, estimated 1 in 1,000. A planned trach is much safer then.
What about timing? Early versus late tracheostomy? Still debated.
Very much so. A lot of research here. Most big studies show no major difference in overall outcomes, like mortality, pneumonia, hospital stay between early versus delayed, suggest timing might not drastically change the ultimate result for many.
But some studies do favor early.
Yes, some support early track within 7 days, leading to shorter ICU stays, less time on the vent in trauma and non-trauma groups. That's a benefit for recovery and resource use.
So mixed results. But you mentioned one specific randomized study.
Yes, a key one by Rumback et al. In 2004, in medical ICU patients, it showed a significant reduction in mortality, 32% to 62%, pneumonia, 5%, 25%, and accidental extubation, 0 versus 6, when early track, 48 hours, was compared to delayed 14-16 days in patients predicted to need 14 days of ventilation.
Wow, those are big differences.
Huge. That early group also had shorter ICU stays and fewer vent days. While not replicated everywhere, it's strong evidence supporting earlier intervention in select critically ill patients. It definitely changed practice for many.
Even with good safety data, what are the potential complications of PDT?
Like any procedure, risks exist. Long-term issues like tracheal stenosis aren't perfectly studied in PDT trials, but perioperative complications include peristomal bleeding from the site, more serious, injury to the back wall of the trachea or esophagus, extraluminal placement, false tract, and critically, loss of airway.
How are those minimized, especially airway loss?
General safety measures are key: checklist, timeouts, protocols. Also, those specifically trained procedure support personnel focusing just on the airway are particularly helpful in limiting mishaps. Dedicated multidisciplinary track teams also improve outcomes: faster decannulation, shorter stays, fewer adverse events.
Some technique matters.
Yes. Ensuring proper tube position and minimizing airway loss usually requires either bronchoscopic guidance, camera inside, or a semi-open technique, direct visualization. Important note, even bronchoscopy doesn't eliminate severe injuries. Experience is crucial.
Any recent safety advancements?
Yes, pre-procedure ultrasound of the neck anatomy is increasingly used and helpful.
How does ultrasound help?
Decreases bleeding risk by identifying veins to avoid. Locates enlarged thyroid lobes. Reduces the number of needle sticks needed. Especially useful in obese patients where anatomy is tricky. It gives a visual roadmap.
What about long-term narrowing stenosis?
Serious tracheal stenosis after PDT seems low, around 6%, usually early, just below the vocal cords. Subclinical stenosis, no symptoms seen on imaging, is higher, maybe 40%. Highlights why post-discharge follow-up is really important for these patients to catch issues early.
Okay, next bedside procedure. Percutaneous endoscopic gastrostomy, PEG.
Yeah.
For feeding, right?
Yes, primarily for long-term enteral feeding nutrition into the gut, first described in 1980 using the pull technique.
How does that work?
Scope in the stomach, find a spot, pass a wire out, pull a tube through. It secures the stomach to the abdominal wall without sutures, still the most popular method. There are also push and introducer techniques, which usually need stay sutures to hold the stomach wall up.
And variations, PEG tubes.
Right. percutaneous endoscopic gastrostomy, PEG-J. These have ports for both the stomach and the jejunum, small intestine, allows feeding into the jejunum, bypassing the stomach, good for high aspiration risk while still allowing stomach decompression.
So feed the gut, drain the stomach.
Exactly. There are even multi-lumen transgastric jejunostomy tubes for critically ill patients at high aspiration risk, often with a balloon to keep things sealed.
Who typically gets a PEG or PEG-J. Main indications.
Accepted indications include inability to swallow safely, stroke, dementia, head injury, high aspiration risk, severe facial trauma or head neck cancer blocking oral intake, need for mechanical ventilation over 4 weeks, nutritional access for severely debilitated or malnourished patients. And PEGs have been shown to reduce overall hospital costs, too.
When can you start feeding through it?
Theoretically, same day, but most critically ill patients wait 24 hours. Just a safety margin lets any unseen issues manifest before introducing feeds.
When is PEG not an option? Contraindications.
Clear ones include no endoscopic access, significant ascites, fluid in belly, severe coagulopathy, bleeding risk, gastric outlet obstruction or complex prior stomach surgery, predicted survival less than 4 weeks, inability to pull the stomach to the abdominal wall, severe immunosuppression, low white cells, high infection risk.
Any situations that need extra caution. Relative contraindications.
Yeah. Inability to transilluminate light from the scope doesn't shine clearly through the belly wall, suggesting something's in the way. Gastric varices, bleed risk, diffuse stomach cancer. Practically, supermorbid obesity can make it nearly impossible due to abdominal wall thickness.
What about inflammation or other devices?
Active inflammation on the abdominal wall should be treated first. Ascites might be drained if no other choice. PEGs can be placed with VP shunts or dialysis catheters, but ideally separated by 1-2 weeks to cut infection risk.
And prior abdominal surgery.
Not an absolute contraindication, but need caution. A CT scan beforehand might help check for a clear window, no bowel stuck between stomach and wall. Always need to feel that discrete indentation and see good transillumination key safety checks.
How safe is PEG overall? What are common complications?
Generally considered safe, whether in GI lab or R or bedside, but because patients are often debilitated or critically ill, complications carry a higher mortality than would be expected for most elective procedures. Patient fragility raises the stakes.
Makes sense. What are those common complications?
Free intraperitoneal air is common after, usually harmless, can last weeks. Abdominal wall infection is an early risk, minimized by ample skin incision, no closed space, and pre-procedure antibiotics. More serious is PEG dislodgement.
The tube coming out.
Yes, acutely from traction or necrosis if the internal bumper erodes through the stomach wall from too much pressure.
And if it dislodges early, before it heals.
That's a surgical emergency, critical. If it happens before a mature fibrous tract forms, first 10-14 days, stomach contents spill into the abdomen. Peritonitis, sepsis, needs urgent surgery to close the hole.
How do you prevent that?
Meticulous methods. Secure fixation externally. Record and routinely check the tube position at the skin. Use binders to limit accidental pulling. Constant vigilance is key.
Okay, last one. Bronchoscopy at the bedside. What's it used for in surgical critical care?
It's versatile, used for both diagnostic and therapeutic reasons.
Therapeutic uses.
Inserting endotracheal tubes in tough airways. Removing aspirated foreign bodies. Clearing stubborn mucus plugs blocking airways. Reversing atelectasis, lung collapse, by suctioning or recruiting lung. Suctioning fixed secretions, diagnosing obstructive pneumonia.
And diagnostic uses, especially for pneumonia.
Most common diagnostic use is getting pulmonary specimen samples from the lungs. Critically, quantitative cultures from bronchoscopy measuring bacteria amounts have shown big benefits. Like what? Can eliminate the diagnosis of pneumonia in nearly 50% of patients with signs but another cause. Decreases inappropriate antibiotic use. And importantly, these quantitative techniques have been shown to improve mortality compared to non-quantitative methods. Standardization of culture technique is vital here.
What are the risks of bronchoscopy, especially in sick patients?
Risks exist. Primary risk in non-intubated patients relates to conscious sedation meds, can depress breathing, make airway vulnerable, risk aspiration.
And procedure-specific risks.
Pneumothorax, collapsed lung, hypoxia, low oxygen, airway hyperreactivity, spasm, pulmonary hemorrhage, bleeding, loss of pulmonary reserve, especially if already on high vent settings, systemic effects like blood pressure changes. So like all bedside procedures, careful risk-benefit assessment is paramount for each patient.
This deep dive has really illuminated how surgical care is changing in the ICU. It's so clear that bedside procedures are a profound strategic shift.
Absolutely. Moving life-saving care closer when stability and seconds count.
The core lessons are striking. The careful why behind avoiding transport, the ingenious ways the OR is replicated in the ICU,
Adapting that
and
environment.
the rigorous safety protocols,
Yeah.
borrowing from high-reliability fields, and the vital role of those dedicated support staff. It all has to work together.
Absolutely.
That-
And understanding the specific, often life or death situations ACS long-term ventilation needs where these are used really shows the adaptability and collaboration in modern medicine.
It really does. So as we keep pushing these boundaries, doing more complex surgery at the bedside, outside the traditional OR, what does this mean for how we even define an operating room or surgery in the future?
That's a fascinating question.
How might this blur the lines, between surgical and critical care specialties?
Yeah.
Foster even deeper collaborations? And what totally new innovations might pop up from this convergence?
It's a truly compelling thought for where healthcare is heading. This shift really makes you reflect on the immense expertise, the innovation, the deep teamwork needed to make bedside procedures a reality.
Yeah.
And maybe consider how this advancement might reshape healthcare systems more broadly, really putting the patient's immediate need right at the center. It's a testament to ingenuity in facing complex challenges, always striving for better, safer outcomes.